Hey, everyone, welcome to another book live presentation here by National Institute of Medicine. I'm Instructor Stull, and I'm here with good friend Robert, and today we're going to be talking about percussive therapy. We're talking for the science and application. So thank you very much for being on the call with today. Take a few minutes here and tell everybody about you, who you are, what you do, and a little bit about where you're from, because you have an excellent background.
Thank you, and really appreciate the opportunity to discuss this topic with you today, Kyle. My name's Tim Roberts. I'm the Director of Science for Therabody, formerly Theragun, and I'm a sports by I've fortunately spent the last 10 years working both from a research role and then I think importantly to treat that implication. I was with ACES, I was with the Gatorade Sports Science Institute, working with everything from sports all the way through to the elite athlete, and it's kind of January time, I've joined Therabody full time, the Director of Sports Science, and really the goal for us is how does science really impact every part of the business and kind of strategically executing that, and most importantly is what is how it impacts both our education and our innovation as well.
Excellent. And this may be a little bit, I'm not quite sure the right word, but you coming from Gatorade Sports Science Institute, I imagine you have a strong background in hydration, and I'm wondering if you're bringing that to the percussive therapy and to the Theragun research. Are you interested in that types of things, fluid dynamics and local tissue hydration?
Absolutely, a component of it. I think as we go through it, I think when we think of percussive therapy, there's probably a lot of different mechanisms that are happening, and those mechanisms lead to a variety of effects and benefits. And hydration is a key component of it, and so we're actively kind of looking.
Excellent. All right, so looking here at the slide that we have, here's our little agenda. So we'll start off by defining percussive therapy. So they're a massage therapist myself. I think I was taught a different definition, but we'll talk about that whenever there. And then we'll look at scientific rationale of the application of percussion, and then we'll look at the ongoing emerging research. And we'll spend a good bit of time today also looking at how that translates to application. I think this is going to be a big thing for the listeners or the viewers today, is really starting to learn how to use these tools. I know there are a lot of them out there. Some people are getting some education on it, but yeah, I think it'll be great to look at your perspective on that application. And then we'll also look at the landscape of devices. So we'll talk about some of the different devices out there and things that make them different. So let's go ahead and come to the next slide, and we'll let you take it away with the history.
No, I think we wanted to include a couple of slides when we define what percussive therapy is. I think it's important to provide a little bit of background, a little bit of context, and kind of to it. So the first thing I want to discuss is kind of the concept of pressure, and that ultimately humans have understood that pressure has benefits on the body for literally thousands of years. Whether that's kind of when record massage might have been introduced in civilizations. More recently, a few centuries, massage became more formalized through the Swedish influence. It became recognized as having legitimate therapeutic effects, and the Massage Therapy Association was formed, as well as physical therapists using manual therapy, etc. And then when we think about the last 30 years, and we think about the application of pressure, you've got all these types of devices and services, whether it's active release technique, it's IASTM and GRASTM and kind of instrument assisted things, or whether it's even foam rollers and those types of myofascial interventions. And obviously, Carl, you've had a significant role in the research of the myofascial intervention as well.
I've had some part perhaps, but one of the interesting things about foam rollers and the use of different tools, and says whenever I was writing my book, doing some of the research, I started digging into U.S. patents, and I was able to find that date all the way back to the 1800s, or some type of a roll device. And back then, they were all used by a physician or a doctor or some sort of a therapist. But I think 1890, maybe 1891, their U.S. patent filed. They called it an electric magnet or magnetic massager. So it really goes back a long time whenever people started to come up with devices. I know we only have an hour here, and I knew I would do this and get us off track. in my little patent search, one of the most interesting type of massage that I found was a hoop. You're familiar with hula hooping? That
Yeah.
had spikes built on the inside of it. And these spikes were designed to massage the abdominal region. And it probably was something of getting rid of the fat on the love hand or something too. But this was made to massage the abdominal region. And that was early 1900s. A patent was filed for that. So there's a very interesting history behind all of these tools and processes. Let's go ahead and click on to the next slide.
Yeah, and the other history, which I think is really fundamental to kind of understanding what we're going to talk about today, is that of local vibration. And again, if you look back at vibration in general, it's incredible how long it's been used for. To your point with pressure in the terms of therapeutic effects, specifically kind of the medical side of things, and then more recently outside of that scope. Whether it's kind of, again, ancient Greece, whether it's then being, again, Sweden and kind of their kind of transition of taking these mechanical concepts and them in different settings, and the introduction of kind of vibration in exercise. And then in the 1960s, obviously another topic is whole body vibration, and we're talking really more about local vibration of local tissues. In the 1960s, that's when they really started to do the research in terms of both animal models and then also in humans, looking at the effects of vibration on the muscle, on tenderness and connective tissue as well. And then you think about it today from kind of the last 20, 30 years, whether it's in physical therapy, whether it's in practice, whether it might be in spas in terms of massage, the use of mechanical vibration and especially local vibration is quite common.
Yes, and in massage, we were taught a vibration technique or a vibration movement. I'm an LMT. I don't practice, but I keep my license up and everything. But we were taught, local vibration. It was simply just shaking of the tissue, the muscle. It's a couple different ways you could do it, but it was basically just shaking it. And that's one of those that, again, it's been used for more than likely 100 years of just shaking. We see it. I know it talks about it a little bit more in the presentation, but whenever we look at it, it's analgesic effect, or that the pain reduction. We can, if we have some sort of you bump your elbow on the door, if you just shake it, that local vibration has pain modulation effect. So it's really been used. I think it's intuitive to use local vibration on painful spots. So great history there too, and much of it we just do intuitively. All right, so let's go ahead and click on. Go ahead.
So you're absolutely spot on. It's that natural action to pain to apply pressure and to rub it to cause vibration. Yeah. It's interesting how humans, we've evolved to do that, and now we're as research continues, we start to understand why we do that. So kind of understanding that history kind of guides us to kind of where we are in terms of therapy. And I think it's helpful to see this on the screen and talk about kind of as percussive is a relatively brand new modality. Where did it come from? And so in terms of its kind of invention and within Theragun and kind of the percussive therapy modality in itself, our founder, who's a chiropractor, Dr. Jason Wersland, it came up. He obviously understood the concept of pressure and the concept of vibration in his clinic and in the application to patients. But then when he suffered injuries, he wasn't getting the relief or as much relief as he wanted from those stimuli alone, from pressure and vibration. So he set about kind of saying, well, is there another way? If I have this vibration tool, could I also simultaneously apply more pressure? And kind of through that, and then as most innovation does occur through the synthesis of different ideas coming together, he started experimenting with other mechanical engineering, hardware tools. So instead of what's been designed for the clinic setting, was there things that he could find in his head which might actually be able to apply to the body? And so as you can see from 2008, which is now 12 years ago, and percussive therapy really isn't associated with being around that long ago, he was tinkering and playing to find a solution that wasn't really meant to be a product, but it was meant to kind of help, and has evolved to the point now where we have the modality of percussive therapy, and we have these kind of very advanced percussive therapy devices. And I think so that's kind of the origin story, and I think that goes to the next slide, and kind of completes this when we think about, well, what is percussive therapy? And for us, we define it as the rapid additive application of pressure, specifically perpendicular body, and we can get into this a little bit more as well. And that percussive stimulus actually causes the tissues that you apply to actually experience both pressure and vibration. So that's really for us the key definition and the origin story, and through the history that we've just discussed.
And whenever in my training, we were taught a percussive stroke, and there we called it tapotement, and it was one of the 5 key strokes or 5 key movements. Sounds creepy to me. 5 key movements in Swedish massage, but we would oftentimes, or we were taught, you could do it in different ways, but you use the ulnar aspect of the hand, and it's just a stream motion. And you could use different hands, just striking. And we were taught that, I believe they called it hacking. I think hacking, if you have your fingers loose, whenever you do the striking motion, each finger will come down and hit the finger below it, and that creates, they said, a vibration as well. So by having fingers loose and striking this way, in massage anyway, they said it was a combination of percussive and vibration. And I think it worked quite well, but the obviously the advancement of technology and being able to develop devices to do this, I think it can really amplify so much, and so much so, I think it can also give us different effects. So we can take it to a level to where we're actually stimulating the tissue much differently than a therapist could with their hands. And going back to those older devices, I remember stories of Clark, who was the founder of NASM's OPT model. They said that he also, I want to say this is maybe mid to late 90s, but don't quote me on the date, took a jigsaw just from Home Depot or whatever, and put a rubber stopper on the end. So basically, just like you were talking about there, taking from something from the tool shed and trying to use it in a therapy application.
No, and I think I'm very fortunate that my wife is also an LMT, and the tapotement which you discussed. It's interesting that you described the way that you hold your hands in different positions, and we'll actually talk about it a little bit later in terms of application. It has carryover to how you change kind of the area that is impact with the body, and kind of how we think about attachment in the application thing a little bit later.
Yeah, excellent point. Excellent point. All right, let's move on to the slide.
Yeah, so with this slide, in terms of the definition of percussive therapy, I think it's important to call out 3 key components that separate it from kind of either being an individual pressure stimulus or an individual kind of vibration stimulus. The first component to call out is the amplitude. And when we think of amplitude, a lot of people most about this is just the distance that the head of your travels. That I think the amplitude is, but I think it's very important that it is that. It's also important to just the direction that it travels as well. Because when we think of vibration is simply kind of the oscillation of movement from an equilibrium point in any direction. And amplitude for us, percussive therapy is perpendicular to the body, and it's of a large amplitude as well. So when we think about local vibration research, it's typically being done in very small amplitudes. Percussive therapy, because of the mechanical engineering, has become more advanced to be able to allow us to have these larger amplitudes. And for reason, your amplitude affects not only the pressure being to the body because it is perpendicular to it, but also kind of size of that vibration stimulus. We think about the next component is going to be frequency. Obviously, this is how fast is it moving. So how many times per second is that because stimulus being applied to the body, and obviously that is relative to causing the tissues to vibrate. And then lastly is the torque. In kind of motor past, you have a torque which you might be able to override, but torque is really how strong the motor is. And if you want to be able to sinusously cause pressure and vibration to the body, you need to have the high enough torque to be able to apply it without that much stalling. So I think that complements that definition and kind of describes some of the components of these devices.
On the amplitude specifically for the Theragun, do you know if different amplitudes were tested, or do you know why it was settled on the half-inch amplitude?
Yeah, it was kind of over the years, several different amplitudes were tried and did, and when you amplitude, it also has kind of repercussions to finding the right that can actually create that amplitude at the frequency as well, and with enough torque. So when you think about these components, they actually kind of synergistically work together. And so the amplitude, for us, it was about, and for Dr. Jason, as he went through that progression, was about what is it to get as much amplitude as possible while still being able to create a frequent stimulus as the torque, and then what amplitudes are we seeing have therapeutic effects as well, kind of as we look to kind of advance what the product is.
Okay. Would you say that greater amplitude is better? Is this a greater is better type of scenario? Greater to the point that it can still fit into a usable device?
So we actually have some research. It was what we compared a device with the amplitude it is to a competitor's device with a smaller amplitude. This was a poster presentation and an abstract for ACSM's meeting in 2019. And in that, we saw that the effects that were being measured were blood flow and fluid distribution changes. And we did see our device with the high amplitude as well as the high torque was actually able to elicit kind of large effects, a little bit longer lasting effects when it came to the blood flow. And it seemed to be able to alter fluid distribution where the other device didn't. Personally, we need to do more research, but to me, that's very encouraging. And it leads to the kind of conclusion and the hypothesis that the larger the amplitude, it's going to elicit greater effects. And we need to now test this in some of the other we'll discuss shortly in terms of muscle tone, neuromuscular function, the protective effects against soreness, etc. We've only that in blood flow, but it's very encouraging, and it says to me that amplitude probably plays a significant role in that.
Okay. Do you think? Well, let me preface this by saying in our foam roller research, and I've taught foam rolling for a lot of years, and it's very challenging. You have to teach somebody how to put the roller on the ground, put their leg on top of it, and roll. You may not understand right now, but once you practice a little bit, you'll get it. But anyway, so for years, we always assumed that harder was better. You take a harder roller, it's going to travel, it's going to use more layers of tissue, and it's going to be more advantageous. However, as we're getting into our research, depending on the population, we started learning that that's not necessarily the case. Sometimes the rollers just hurt too bad. So whenever it comes to amplitude, do you also think there is an aspect of personal preference? Okay, I think we'll stop the question there. Amplitude.
Yeah, no, absolutely. I think what you have to recognize is that while the amplitude of the device is constant, you also are in control of the device and how much force that you have. So in terms of the actual, let's call it the pressure that the tissue experiences, it's a product of both the amplitude and the force. So I think for us, and we'll talk about this a little bit more when we talk about the way that pressure and vibration kind of elicit and stimulate mechanoreceptors and the location of those mechanoreceptors. Some are cutaneous, some are a little bit deeper in the muscle. I think we can talk about not only personal preference in how we use it, how hard we push, and how much pressure they experience, but we can also talk about how we might change that on purpose to potentially elicit different effects.
Okay. And I guess on the personal preference side too, the different attachments can have a big influence in that.
Yeah, and we'll talk the attachments a little bit later in that application side, but I think it really comes down to, again, personal preference, but very purposeful design in terms of the surface area, the density of them, and we know that obviously changing surface area, changing the density of the attachments, then also alters that tissue will experience.
Yeah. Okay. Excellent. For the next slide. And sorry, I think I have too much. I'll put a.
Yeah, so this is kind of an intro slide for us as we dive deeper into the science, and it really to set the. I think when we think of the research that's being done in pressure and vibration and the history of that, and to your point, the patents that have been kind of over a century ago, and the research that's been done over the last 100 years, and we think of percussive therapy being, in that case, a relatively new and research has not yet caught up. And for us, when we think about it, the scientific rationale that we build that helps us not understand how we explain the effects of percussive therapy, how we apply them, but also how we drive our own research strategy is really built around pressure and vibration. That's our kind of scientific rationale and how we kind of approach it. And again, we kind of accept that while that rationale is it helps us kind of educate and it helps us kind of really channel where we're going with innovation, et cetera, and education, it's not good enough. So we're proud to say that we actually have kind of 20 ongoing studies across a lot of academic partners, and that we also have many more that we're in the planning stages of, because we believe that while we've built rationale, now we want to go back and kind of and prove it in terms of percussive therapy. And it's exciting that some of the emerging research that we do see the same effects as pressure and vibration, but we also start to see that with percussive therapy they might be a little bit greater as well.
Okay, and going back to some of my award-winning massage therapy training. So we were taught differences between percussion and our percussive therapy and vibration, and two key things. One, percussive therapy was to be more direct, so it was like a more direct type of a movement, and kind of like you were saying too, that would be more perpendicular to the fibers. And vibration was taught to be more of a I don't want to use the term global, but it's still local to the muscle. It's more than just that direct, because it would be kind of the shaking and stuff like that. Another part of it too was that we were taught that vibration was more consistent. So a vibration type of a therapy is something where the tissue is being continuously moved. As with percussion, there would be a strike and then a moment pause, and then another strike and a momentary pause. However, to your point as well, we see that the effects could be very similar. Now, we could take with a percussive device and be more direct and more specific than the vibration, but so a little bit different there in application. However, the effects appear to be, like you said, very close to the same.
No, absolutely. And what's really interesting in terms of the LMT being kind of, I guess, so ahead of the technology side of things is the LMT is limited by them being a human. And so now when we add a device to that, in terms of the percussive nature, the force or the vibration, one thing that we can translate the percussive stimulus and actually the frequency of some of those of some of the vibration. So whilst the direction of the force and kind of the application of it is in the same direction as percussive in LMT world, you now can do that at 4 times per second, whereas your hands move that fast. So this is kind of where we have this real integration of these effects.
Yeah, excellent. Let's go on to the next slide.
So as you're really aware, in terms of when we look at the effects of foam roll, as an example with pressure, or the effects of vibration, it can be really complex. You can go into some deep neuromuscular physiology, and for us, when we kind of edge this topic, our goal is to kind of tell a story which is digestible, that translates easily in application. So today, as we discuss it, just kind of the overview is we're going to start with the physiological and neurological responses that we see from pressure and vibration, and our research in percussive therapy as well. Then we'll discuss some of the benefits and effects of those, and then kind of we'll take it to the kind of the conclusion. It's like, how does this all? Why does the science matter, and how to actually apply it? So that's kind of how the narrative of what we'll discuss. If you want.
Excellent. On to the next slide.
So in terms of physiological and neurological responses, what we believe is very important when you look at the literature and we discuss percussive therapy and observing that most these different responses in the physiological and neurological, they're happening actually in the local tissues themselves, but there's also global responses that are occurring as well. And I think obviously something that you're very familiar with your research, we can kind of run through. We can kind of discuss that, the idea of local and global effects, but then we can go through these as well, whatever you want to do.
Yeah. So whenever we look at some of the effects, and with my foam rolling research stuff, we looked at quite a few things. Vibration. So I know as much about percussion, so I'll just relate this a lot to vibration, and we can kind of take it from there. But found a couple of different things. So with foam rolling injuries, that mechanical effect and that physiological. Mechanical is going to be the direct tissue change of compression, and then the neurophysiological is going to have influence on the nervous system. And whenever we started to add in vibration, we started to see a greater neurophysiological response than the mechanical response. And that was also as well with the percussion. And I know we have a couple of the studies on the next few slides there, but what have you guys looked at as far as that goes on that neurophysiological versus the mechanical?
Yeah, I think we we've kind of followed the same track as you discussed, because we had to build a rationale for what research we do and what are we going to look at. And I think the way to think about it is that pressure probably has some kind of pathways and mechanisms, and so does vibration. And so when we think of kind of these stimulus and we think of the mechanoreceptors and we think of effects of those, then we can kind of start to explain some of the things we're seeing in terms of reduced muscle tone, not only from it, and when we think of it in that neurophysiological thing perspective, reduced muscle tone in the limb that's being treated, and then also in the contralateral limb, and whether we're seeing things that changes that we might relate to autonomic nervous system, kind of your parasympathetic nervous system, and kind of that overall global relaxation, compared to being actually that tissue, that kind of local tissue having that change as well. So kind of, and that's been our approach. And really, it's these set on the screen of the different responses that we believe, whether it's through our own research or whether it's through looking at pressure and vibration, we believe are responsible for the effects observed with percussive therapy.
A quick question. So whenever it comes to percussive therapy, I believe it is often thought, or maybe it is actually true, that it is more of a stimulatory type of a therapy. Like we would use that percussion to stimulate or upregulate a muscle. What are your thoughts on that? Does it rely specifically on application of the percussive therapy?
Yeah, so my personal belief and the kind of hypothesis, looking at all the science and the available information we have, is that it really is down to the application. If we focus on it in kind of from those effects, if we focus on the stimulation of mechanoreceptors, we know there's some mechanoreceptors that kind of reside in the cutaneous tissues. Some of them are a little deeper in the muscle tissues. Some of them are found more towards the origin insertion in tendinous tissue. And these different receptors, some of them will respond very well to vibration. Some of them won't. Some of them will respond very well to pressure. Some of them. And so when you kind of look at it, you can say, well, if I target this area of the tissue, I know that vibration is most likely to have a, like, for instance, if we talk origin insertion, we might target Pacinian corpuscles in terms of vibration, the GTO in terms of applying pressure, and then see some sort of elicited. And when you look at the very complex local vibration literature, by applying local vibration, you can see both inhibitory effects, where we look at reducing muscle tone, relaxation, increasing range of motion, but also you can see very stimulatory effects as well, as you described, where you actually look at, for instance, potentiating the stretch reflex, which is obviously involved in kind of sports performance, etc. And also you start to see some increases in corticospinal excitability as well. So motor evoked potentials and the ability to elicit force is actually also affected. And so it's kind of our goal now for our research is kind of digesting all of that research, doing our own research to kind of to support it, and comparing, to your point, if you apply the percussive therapy here, what's the effect you elicit? And if you apply it in a different area, can you do it? And can you create it? And what we believe is that because of the nature of percussive therapy, because of the understanding of the responses of the body, we can actually use the same tool, both from a recovery and relaxation perspective, but also from a stimulation and duration for physical activity as well.
Yeah, and I'm going to add to that. I think a lot of it has to do with treatment time. So if we look at some of the research on neurological disorders and post-surgical research, we see vibration is used quite often, but it's usually a very short treatment time. So we'll just do real quick vibration and then relax, real quick vibration and then relax. And that is thought to sort of upregulate the tissue. However, we could, and I'm going to hypothesize a little bit here, we could take the exact same settings. We wouldn't have to change anything, settings of our tool, but apply that same treatment for longer. And I believe that we would use those same reflex mechanisms, but whenever you hold that over time, it actually fatigues them. Instead of upregulating that stimulating that mechanoreceptor or reflex, we can hold that to where we fatigue it, and then we kind of get that opposite effect. So I think treatment time will play a big role in that.
Yeah, no, 100% agreed. And it's really everything you've discussed and kind of we discussed so far is really guided how we talk about the application, because you're in control of so many with a percussive therapy tool, with a Theragun, you're in control of many different variables: duration of treatment, location of treatment, and discuss a little bit later, are just a couple of them which we kind of change based on what the effects that we're trying to create, and based on the needs of the individual, the demands of their training, or their needs from a recovery standpoint.
Yeah, excellent. And one thing I wanted to add to this slide here, whenever we look at talking about the bullet point on mechanotransduction and Davis, in my experience, the way I've used these types of tools, massage, even foam rolling, we would focus on some of those other things, such as the stimulation or the relaxation of mechanoreceptors, pain modulation. So we would combine those with something like movement. So whenever we start to apply, NASM's corrective model, whenever we apply things like stretching, neuromuscular stretching, and movement, that's really where we can start to take advantage of Davis's law, which is the realigning of soft tissues along lines of stress. So what I would say here, or I guess it's a question too, do you believe, or have you all found that this in itself can realign scar tissue, or realign, reform its direction, or apply this with other modalities to achieve that effect?
No, great. I think for us, it's we're actively pursuing how we, if the case, it can be a passive tool for, but at the same time, we believe that it creates a window of opportunity to create like a movement or exercise intervention, which allows you to do that. And I think when we think of mechanotransduction, anytime you apply these mechanical forces, obviously shear, stress, tension, stretch, and for us, vibration to the tissue, you see mechanical transduction in terms of you start having these biochemical signals, which they can be related to inflammatory responses, or they can be related to kind of your protein synthesis, kind of your structural adaptation path as well. And so for us, we think because you now have a tool which you can apply substantial mechanical forces, so we're researching, does this have enough in itself to create this imposed demand for Davis's law, and if so, then you have kind of that double approach. You have the ability to passively do it, create a window for that active stimulus.
And I think it's an excellent way to put it, a window of opportunity. So if somebody, not that we work with people in pain or fitness professionals shouldn't, somebody in pain is outside the scope of practice, but let's say somebody has soreness or something there, we could use a tool such as this for percussive therapy to provide a window of opportunity, wonderful way to put it. And then we can, reestablish better movement patterns within that window. On mechanotransduction, ways I like to describe this is it's the body. The body has a cellular response to mechanical force. So for those of you, if you don't know what mechanotransduction is, it's that the body will have a cellular response to the mechanical force that's applied to it. So that is mechanotransduction. If you're going to sit and take the NASM test, let's go ahead and move on to the next slide.
Yeah, so those are some of the physical neurological responses that are occurring, and kind of talking more from a mechanistic standpoint. But when people think of percussive therapy devices, Theragun, you actually are thinking more about those observed effects that you see. So whether it's reducing acute pain and soreness, whether it's protective effects, which I actually discuss a little bit more, decreased muscle tone, improving passive and active range of motion, neuromuscular performance, and so on. These are the once we understand the mechanisms, the effects that they elicit and benefits of these, it's really this group, this slide, which then drives, okay, well, how are we going to use Percussive with our client, with our athlete, and to make sure we get the most out of the tool. Carl, quickly, just to talk about the protective effects, what's really interesting is that if you look at the research on vibration itself, if you do vibration pre-exercise, there's actually a decent amount of research showing that it can actually attenuate the soreness and kind of the reduction in range of motion that you typically get post-exercise with an eccentric stress. And they've not only done the research looking at kind of those more applied functions such as pain and range of motion, but they've actually looked at it in terms of the biochemical markers as well. So if we know that physiotherapy elicits, that it causes the tissue to vibrate at a frequency, you can start to think this is another one of those ways where you talked about stimulation and relaxation in terms of using the tool. You actually could potentially not only reduce the pain once you have it, but actually maybe kind of reduce the you experience by actually using it as part of your warm-up as well. So for us, that's another kind of from a rationale that we've built from listing literature and that we are now kind of pursuing on our own research as well.
Excellent. That's very interesting. Sort of related. I remember our old foam rolling study, and I don't remember exactly the areas. I say really old is 2005 or something. I don't remember the exact areas they rolled, but they found that rolling for exercises delayed fatigue. So in their control or the comparison was holding a same position as you would with the roller, but that roller, it seemed to delay fatigue, which kind of seemed interesting to me. I don't know if that study was ever repeated.
It's
interesting.
Between that study and kind of the studies that we look at, kind of like vibration and having these protective effects, I think really you can hypothesize that if you come to neuromuscular function prior to exercise, maybe increase blood flow, the delivery of oxygen, which we know are occurring as well, then it's those mechanisms which then potentially, if you whatever the absolute load of that training or exercise is, it may actually reduce the relative load. And potentially that's why you see fatigue kind of reduced and maybe that soreness as well. And so that's, as a scientist, that's kind of what I hypothesize is really happening.
Excellent. All right, let's move to the next and talk about a couple of these.
Yeah, so obviously we talked a lot about the rationale, the ongoing research that we have, the both from pressure and vibration. And kind of really wanting to highlight some of the things that we've done and that we can share. Obviously, research is not a very quick process; it's a slow process, and we've got some fantastic partners that we've worked with. And really, our strategy is we obviously want to confirm the mechanisms, confirm those observed effects that we know with pressure and vibration, and that we see anecdotally with percussive therapy. We obviously want to optimize application and our education, and then obviously we want to identify key use cases. There's a lot of research in Parkinson's with vibration to reduce tremor. There's post-surgical interventions that could potentially benefit from percussive therapy. And so that's what drives us. And to highlight a couple of these on here, we have a great relationship with Professor Eddie Joe at Cal Poly. These are two student posters on the other slide that he's just presented, and he's actually currently writing up the manuscripts. But he was able to show that the percussive therapy using the Theragun was actually able to increase active range. We knew we had research previously that showed it increased passive range of motion, but now it's increasing that active range of motion as well. And that also, he did another study to confirm for us that we have these increases in blood flow up to 10 minutes post-treatment. And also this alters the hemodynamics, so the oxygen saturation of the muscle as well in terms of, and obviously that is a really interesting thing in terms of preparation for activity. Obviously increasing flow of muscle oxygen is part of why we come up and try and increase blood flow, but also it has probably implications for the recovery and delivery of nutrients, etc., and increase of venous return post-exercise as well.
So real quick on these, whenever I was looking through them, and thank you for sending them to me. A couple of the studies used 2-minute treatment time, and the other two used a 5-minute treatment time. Do you know the reason for the difference?
So as you know, when you research, it's incredibly difficult to approach an area that has almost no research for, and to do it in a strategic manner. Yes. We want to elicit what effects and what mechanisms are we doing, but also we want to be able to kind of systematically change variables as well. Or does treatment have a different effect to you earlier compared to treatment location? Does the direction of application compare kind of the movement that you actually applied onto the actual body there is as well. So currently a snapshot, and because so much ongoing research, our goal is to try and create that systematic approach so that we can start to elucidate. 2 minutes and 5 minutes, they're exactly the same, but 30 seconds and 2 minutes, you might have kind of a different effect. And so, and then simultaneously in our research, when you're doing both pressure and vibration, you have to account that they might be having different effects as well. So it's a fun challenge to have, and it's something that you'll see over time, that as the body of literature on percussive therapy increases, as Therabody leads that, we'll start to be able to kind of call out very definitively why we approach certain things certain ways.
Yeah, that's great to hear, because that's been I would say it's a huge problem in foam rolling. After a decade of research with a lack of consensus on methods, the end result is a whole bunch of information that people don't know how to use. So you have people out there rolling, and it looks like they're trying to fire in between the roller, or their leg, or whatever, and you have other people that spend 45 minutes rolling. And not saying that either way is right or wrong, but I think it's really important, especially as you're growing. I know you know this, so I'm just kind of repeating, but it's really important to establish those solid methods. And with something like percussive therapy, like you said, there's so many different variables. I imagine it will take a while to really try to narrow it down. But ideally, we need a predictive application. People, it's the same for rolling too. So it's all these these types of treatment styles. Fitness professionals need to know when and how to use it pre-exercise. They need to know, and not they would admit this, they also need to be exactly what setting. They want to know what setting to put, how long to do, whether they need to hold it in position or just kind of massage muscle. They need to know during, they need to know exactly what setting, how long the treatment time, and post. They need to know those exact things. So I know you're working on that, but that is one of those things that I've been very fortunate to work with Dr. Scott Cheatham, because he is an excellent researcher, but that's very important to him. How can you really grow a body of research if you don't have consistent hits? So good to hear you're working on.
The fun challenge is that I think it's always, as fitness professors, it's always a balance of taking the literature as it is, and the way studies are designed, and really trying to pull the principle of it. And I think what we're trying to do with our research, but also acknowledging the research around pressure vibration, is start to pull out these principles in the way that we use the device, build our research strategy around those principles as well, and confirm them, really create that synergy between our research approach, but the education that we can as we research at the same time. Al's point, methodological issues in the way we approach research. If we didn't approach it in a way, we could wait 15 years and still not know exactly what is the optimal.
Yeah, well, and that's the way it is on rolling. We want to know why it works, and to be honest, we don't know why. We won't know why until we have those consistent methods that are being repeated. A couple of things about a few of these, and I know we have 14 minutes left here. But on one of the studies here, the blood flow response and changes in fluid distribution, the findings were that the G2 Pro had a larger and longer lasting effect than the other one. And you were talking a little bit earlier. Is that because of the amplitude that created that effect?
So that would be what I hypothesize. We saw those significant effects and those significant differences between the G2 Pro and the competitive product. And when you look at the products and you compare them, the differences in the amplitude and the torque. So it kind of between those things, when you lower the amplitude and you lower the torque, obviously we described what we believe percussive therapy and what we define percussive therapy is that repetitive application pressure. And when you reduce the torque and you reduce the amplitude, you start back to more that vibration stimulus. So to me, when there's effects, when we see one device and the Theragun alters fluid distribution and the other doesn't, as a trend to that, when we see the significant difference in the increases in blood flow and the duration of that increase, to me, I would conclude that is due to the amplitude, but research would have to confirm that.
Okay, great. All right, let's go ahead and look at the next slide.
Yeah, and we can skip this slide quite quickly and jump to the next one, but just to quickly a few things. We've obviously talked a lot about mechanisms and the physiological neurological responses. We've talked about those benefits and effects, and I think this is the key. I think when you think of all of them, you put it together, you as fitness professionals, you understand the individual needs of your athlete or your client. You understand the demands of their training, and that should guide some of the application. And if you skip to the next slide, this is so when we think of those individual needs, they could have limited range of motion. It could be they have some soreness from their last work. It could be that they've got some movement that you want to correct. So we know the effects. You can increase motion. You might improve neuromuscular function. We can increase blood flow. We can reduce that soreness. It could be that guides you that this is how your client, your athlete, uses it pre-exercise. And when we talk about exercise, it could be your training. It could be from a rehab perspective. It could be in a movement mobility session, but that kind of really drives it. When you think about during and the effects, whether it's to mitigate fatigue, it's during a workout, you might still want to prepare for whatever exercises are next in the programming. And then post, work about kind of individual needs training, what muscles have just been used at workout in that training session. What can I kind of try and maximize that local recovery in terms of reducing the tension there, promoting relaxation, increasing blood flow, etc. And obviously from an NASM standpoint and their corrective exercise, when you think about it from a pre-standpoint, it really is a myofascial intervention in its kind of essence, and can be used in that inhibit kind of process before you kind of go through that continuum.
Mm-hmm. So a couple things on this. What is Therabody's stance on the? I know there's going to be a slide on the education here in a bit, but is yours on themselves, or do you guys approach it by teaching fitness professional how to use it on the client or the athlete?
Okay, so you kind of broke up a little bit, but I think I understood the question. So for obviously we have Theragun University, we have our professional education courses, which we'll briefly touch on at the end. Kind of for us, we believe that percussive therapy is really within the scope of practice. So an LMT course where they should be using percussive therapy on the client because that's within their scope of work. Whether if you're an athlete trainer, we have a medical practitioner course, and physical therapists could use that. It's going to come out later in the year. But from a personal training, fitness professionals, strength and conditioning coach, kind of our education course is built around how to teach the client and the athlete how to use it on themselves, but
Excellent.
Use it on themselves in the appropriate time, in the appropriate areas, in the appropriate way to make sure they elicit the effects that they want.
Okay, good to hear. Good to hear. On this pre, during, and post, right now, are there specific? Is there a specific protocol for each because on this particular unit, you can set the frequency to several different ones. So do you recommend right now higher before, lower after, or anything specific?
So I'll answer that question, but if we actually flick on, in the conscious of time, if we flick onto the next two slides and quickly talk through that, then come back and answer that question. It'll be on the slides after. So I can answer that before we go on, and I'll repeat myself a little bit later. But when you think about all the research that we discussed in terms of pressure and vibration and percussive therapy and that overall body of literature, it certainly does guide us in the terms of pre-exercise. You should probably use shorter durations because you're not going to fatigue that neuromuscular stimulus. You're not going to create kind of that fatigue and that relaxation. You're more stimulatory to improve muscle function. So we'll use shorter protocols. We might use an increased amount of pressure, which on the newest Theragun devices, you can actually have that pressure gauge. So we know that if you're applying greater pressure, you're probably activating your muscle spindles and that sort of things versus the very cutaneous mechanoreceptor. And we'll probably treat both muscle belly, but also the origin insertion because we know the different mechanoreceptors that are there. So that's kind of the preference standpoint. Whereas from a recovery standpoint, when we look at that body literature and kind of try and pull out those principles again, we might want to kind of move slower. We might want to kind of apply less pressure because we know those cutaneous mechanoreceptors are related to your parasympathetic response and causing relaxation as well as increasing blood flow to the area. So very much those effects and the understanding of the science which drives the way that we apply it in that pre, during, or post window. Okay,
excellent. And on the post too, I found the treating using it, but I can't think of anything now. The entire muscle and kind of a rhythmic motion seems to have a little bit better effect on that recovery because it can kind of help flush or move around a little bit more globally, if we use that term.
Yeah, no, 100%. And if you, again, then you tie in some of your expertise from an LMT background and we talk about particular techniques that might be used in lymphatic drainage. We know through vibration and pressure, we increase the local blood flow. Therefore, increase local blood flow. We know venous return has to increase. But then if we actually direct the movement and the direction of the pressure in a certain way, potentially, and this is, again, we have such a wide bucket of research that we want to do, potentially you will start to increase that lymphatic drainage as you start to have those positive effects as well. It's very, very versatile.
Excellent.
This slide, I think people who've probably been kind of reading as we discuss look at the things, when we talk about post, and pre, during, and post. These are just some of the whys, like some of the examples. We talk about protective effect of soreness. We talk about returning from injury, maximizing recovery, improving a warm up, and just some of the reasons in which when we know we see these effects, you might want to use percussive therapy in different time points to try and help the client, help the athlete.
Excellent. And I won't slow us down here. We can go to the next slide if you're ready.
Yeah. A lot of the throughout today, we've discussed the variables that we control. And we've discussed that, yes, you've got amplitude, frequency, and torque, but you also can change how much force you actually applying with the device. You can then change, we discussed earlier, the attachments. So the attachments all come very specifically when it comes to shape and density. And obviously when you change the shape and density, you change surface contact, like the surface area in contact with the skin, and you change that pressure stimulus. So whether it's personal preference, whether it's targeting certain areas of the body, or whether it's trying to elicit certain responses from touching more of the muscle, more of the tissue at the same time versus a very pinpoint, you can change that. Specifically with our devices, you can change the grip. Purposefully designed that, obviously when we think of rolling, we think of myofascial interventions. It can be challenging to reach it in most parts of your body with a foam roller or a lacrosse ball, etc. But the idea is that with percussive therapy, you have a versatile tool that you can actually use by yourself because of the ergonomic design to allow you to reach pretty much all of your body in a very comfortable way without stressing your joints to reach it. And if we skip on to the next slide. And then, again, other variables we've already covered is the speed in which we move. So how quickly are you moving it across the body? You talked about people in foam rollers trying to kind of light a fire because they move so fast. But we can when we apply percussive therapy, we can actually change how fast we're moving. You might think in terms of inches per second, direction and the location of it, and then also the duration. So. And when we take kind of that, obviously today's quite an introduction to the science, and we expand upon it more in our courses. But look at those kind of our understanding of pressure, vibration, and now our emerging understanding of percussive therapy. You can start to pull that science out and really use these kind of six variables in which we can control to drive that application and change it for whatever the needs are that the athlete has.
Excellent. Real quick question on the attachments. Do you, in your education, do you recommend that people start with like the same attachment or a specific attachment to get used to it?
Yeah. So our kind of second attachment in terms of softness is called our dampener. So it's not the very softest, the super soft, but the dampener has got a less dense than some of them, and it's got a kind of a moderate surface area. So again, percussive therapy is this very new modality. Some people have never experienced it. It can look quite intimidating to some people. So by starting with that attachment, it allows people to kind of experience it. And we also kind of simply say is to kind of float it on the body to start with. So if you as you hold it, if you simply float it and kind of experience, well, what is this device doing? How does it? Then you can kind of play and learn yourself in terms of how do you change that force. Okay, change an attachment to something with a smaller surface area. What are the effects as well? So you can change the dynamics to it.
That's an excellent suggestion. And in a very popular instrument-assisted soft tissue manipulation course, one of the first things they do before, and in this education, they're teaching the therapist how to use the tool on the client, but then the client or the patient hold the tool and do what they call just like a feathering technique, just to experience it and get used to it and learn that it's not really gonna hurt them. So that's a great approach, I think. And then another question on some of this. I know we're kind of short on time, but we can go over a few minutes. When would you suggest somebody change the head there?
Yeah, the arm angle. So as we discussed kind of right at the beginning, when we define what percussive therapy is, it's this application of pressure and rapidly perpendicular to the body. So again, the goal of the arm and being able to rotate it really kind of from a versatility standpoint to be able to treat yourself. And this for people in education. what it was. It started with live education, personal trainers, and LMT in terms of professional ed courses. There are 4 hours in that you'll get continuing education units for from a number of different fitness associations. And what we're doing currently is we're also building out a medical practitioner course. And these, if you look on our website, therabody.com, and then /Theragun University, over the coming few months, you're going to see this launched. And not only will there be digital courses available, but virtual distance learning, as obviously in the current situation, as live courses again at some point in the near future as well. So our goal is not only to, when it comes to a percussive therapy device, but it's what is this modality? How do we understand it? And how can people really truly get the best from it? And then also, how can we help people in the fitness community by offering them extra education and the opportunity for those continuing education credits?
Excellent. That's wonderful. I found whenever I worked in products or a little bit on the product side, the people would often buy something because it looks cool, or they heard great things about it. But if they don't know how to use it, then they're not ever going to really understand. They're not going to get that full benefit. So that education piece is huge to help people learn all the different things about it, like the way this moves and the different grips. That never even crossed my mind, of all these big different grips to go along with that. So that is excellent. Greg, see that you're back. Do we have? I'm hoping we're still on. I don't know if we all got cut off and we've just been chatting here the past couple minutes, which would have been fine. Have there been any questions or anything that come through, or do we just need to wrap up and give the offer, the promotional offer?
We did have a question come in from the group, and they wanted to know, back up here, are there any areas that you should avoid using percussive therapy on?
Yeah, no, absolutely. I can start, Colin, then you can jump in. And I think there's the author's name escapes me. I want to say it was Kavanaugh. I don't know, but they published kind of best practices in terms of myofascial interventions, in terms of precautions and contraindications when it comes to things like foam rollers, like any other of those myofascial intervention tools. And for us, we believe kind of very similarly. So example, like if you have an open wound, you shouldn't do that. If you shouldn't kind of use it on kind of the front of the neck or genitalia. You shouldn't kind of use it on any previous injury for a certain stage of the healing, and several other precautions and contraindications that are listed in that paper and that we actually teach in the Theragun University courses.
Yeah, I agree with that. And the authors' names were Cheatham and Stull, and it was published it was published in the International Journal of Sports Physical Therapy. Or we did a recent one. It was a clinical commentary, part one of a clinical commentary, where we tried to take the information from us and some other things and direct it specifically to foam rolling. I'm sure there's some others out there, but we did have one. So that's great, and I completely agree. Anytime there's sensitive areas in the body, and I guess I would say if you think it's a bad idea, then it probably is a bad idea to jam this somewhere. So I would go with that. Also use the client, if a client's not comfortable doing something because whatever, the knee hurts, and so they want to do it by their knee, then don't do it. So that's great. Anything else come through?
Wendy wanted to know, are there any long-term effects on the body by doing percussive therapy?
Any what?
Long-term effects.
Yeah, so it's a very interesting question, because again, when we look at how we approach research and a strategy for a new modality, oftentimes you focus on the acute effects, what happens immediately, rather than what's happening kind of long-term from regular use. And the way I would describe it is that there's some indication that kind of long-term vibration as a stimulus in certain people with kind of certain conditions, etc., might improve neuromuscular function as almost like a training effect over time. We don't know if that's the same with percussive therapy. Maybe it is. But also, if repeatedly using percussive therapy in the ways that we've described today has the potential to improve the training stimulus. So if you think about long-term as this percussive therapy is a tool to help preparation for exercise and help recovery from exercise, overall, then you have this training stimulus, which is potentially over time going to be improved, and you potentially will see greater benefits adaptations. So that's kind of the current perspective I would have on long-term effects of percussive therapy. But again, it's certainly an area of research that we need to pursue as well.
Yeah, that's wonderful, and I think it's important to recognize that this is a very important tool, but it's only one tool in an overall training program. So as long as we're using it intelligently, we're going to see long-term effects. If we're just using that by itself, maybe not. But yeah, great answer.
Yeah. And I know we're going to kind of move on now. We, for all the people who've been listening today, we have a couple of things. The first thing is that if you want to, we have the new Theragun Pro and Theragun Mini. So we have a package of both of them to give away. So if you've been listening and you want to add a comment, we'll randomly select one of those, and kind of we'll then reach out to you and get your details so we can kind of ship you the product as a thank you for kind of participating and kind of listening today. And then the other thing is, I can't see the slides anymore, but we do have a slide that we will put up on where for everyone listening, kind of for the NASM audience, if you want to use the code NASM20, you'll actually be able to get 20% off kind of any percussive therapy products from Therabody.com for the next 72 hours.
Yeah, emphasize the next 72 hours, and I am a terrible host to not have mentioned the giveaway, and for people to listen to the end and put in their name. So terrible. I got kind of excited. But to reiterate, Tim's there, NASM 20. That's NASM 20 at Therabody.com. 20% off for the next 72 hours. And Greg, as far as the giveaway goes, will somebody be able to? There it is. Will somebody be able to comment after we end this, knowing that we're 10 minutes over, and then we can contact them later that way?
Yes.
Excellent. All right, so we're going to go ahead and wrap up here. Again, make a comment there, and we'll put you into a drawing for the giveaway. Tim, I want to thank you very much for your time. It's wonderful. I know I've learned a ton. Is there anything you'd like to add before we sign off?
No, just thank you very much to yourself, Carl, and then obviously Greg, which no one else can see in the background, who's been our technology guy helping this kind of run smoothly. So thank you very much for the opportunity to talk with you today. And then the last thing really is if people have any questions or further follow-up, please feel free to reach out to me. My email's tim.roberts@therabody.com. So if anyone's interested in kind of learning more about our courses or has got questions about the science, please feel free to reach out.
Excellent. Thank you very much. And yes, thank you to Greg for all your work on the back end. And for everybody that stuck it out to the end of this, thank you for your time. I hope you guys as much out of it as I did. And I hope you all have a wonderful day.
Perfect.